All right. So good evening, everyone, or good afternoon and morning. Depending on time zone. Uh, Welcome to our 14th virtual shadowing session. So our topic for today is going to be talking about disaster medicine. And we have a very special guest who's joining us today who's going to be talking about that. Dr. Fowler will introduce him momentarily. If you
go ahead, please.
Want to go on the slide. This is just our virtual shadowing working group. We have Reagan, Cheyenne, Taylor, Alana, Rachel, and Miriam. And of course, we're always grateful to be joined by Dr. Fowler and Dr. Morchetti during our sessions.
Next slide, Jeff.
Here's some upcoming sessions. Dr. Fowler, I'm not sure if you wanted to go more into detail about what's coming up this month of September.
Sure. We have some very exciting talks coming. Jessica Pretty from Oklahoma will be talking about the view. Let's stay on that slide. The view from the perspective of the health professions advisor for a university. It will be a very interesting talk and about how you students, all 1,000 of you, prepare to enter medical school and physician assistant school from the perspective of the health professions advisor. We'll have a very exciting physician next on the 15th, Dr. Jeff Luna, terrific doc. He's a family medicine doc, and he'll share the perspective of how to do medicine in the much more rural environment. Gil Salazar is going to join us. He's one of our faculty here, and he's the section director for EMS education here at UT Southwestern, and he'll be talking about the future of artificial or assisted intelligence and innovation in medicine. This is a talk that you don't want to meet. Gil has a lot of great ideas about the future of maybe doing actual virtual patient encounters, which we'll be talking to all of you about in the next few weeks. And then finally, on September 29th, you're going to hear a wonderful talk from Dr. Christo Phillip. Christo completed our emergency medicine residency program here at UT Southwestern and has been a physician missionary all over a significant portion of the world. And he will present disease encounters on diseases like tetanus and rabies that we don't see here in the United States. That'll be a fascinating talk, and you must come and join us for that. Ani? All
right. We'll have 2 Q&A sessions over the course of our discussion. So feel free to post any sort of questions that you guys have in the group chat, and the working group will go through it and be sure to have your question answered during your Q&A sessions. And any questions regarding the quiz, please hold off on that because we'll get to those at the end of the session. And due to sort of recent revelation, we sort of instituted a code of conduct for our group chat. So we sort of implore everyone in our virtual session to follow these guidelines and maintain a sort of professional demeanor in the group chat.
All right, next slide. So allow me to introduce a very extraordinary person, Jeff Beeson. I met Jeff when he came to our emergency medicine residency at Parkland and UT Southwestern, and he rapidly became one of the closest friends I have in the world. He's a wonderful physician. Jeff has an extraordinary story to tell about where he came from and what motivated him, and he can tell that story far better than I. But he has risen to the tops of the national heights of emergency medical services and disaster preparedness across this nation. I've had the opportunity to be on many national stages doing lectures with Jeff. Not of a crowd of 1,200, though, I must say. And so Jeff is a remarkable, extraordinary person. We also welcome his daughter, Darby, tonight, who is an Aggie down at Texas A&M, and she is in pre-med as well. So Beeson, my friend, my colleague, my Mutt and Jeff buddy on national podiums, welcome to Virtual Shadowing. Thank you for joining us, and why don't you take it away?
Great, thanks. I hope everybody can hear me. Nods, shakes.
Yeah, we got it.
Few interesting middle fingers there, but thanks. We're just getting started. So I have to put this disclaimer up because what I'm about to say does not represent any of my employers. And what comes out of my mouth is not their fault. I blame my family. So I think it's interesting when I get to know people, especially medical students working at the university, is where people come from. And so it really explains a lot about the person you are. I know Fowler very well and his strong family upbringing. So my life was more doomed into emergency medical services because that's what my father did. He, before the Vietnam time, worked for sheriff's department, so in law enforcement. He worked in the days of ambulances when they were funeral homes running them. Got drafted into the Army and worked as a corpsman, and then, of course, worked at Fort Campbell, Kentucky on their ambulance service. Got out of the military and ran one of the first hospital-based ambulance services in Texas, and that's where these pictures are from, which is in San Marcos, Texas, back in the late 60s and early 70s. And so this was really before there was formalized emergency medical education. A lot of ex-military. At that time, a lot of things that we were doing in the hospital, we took into the pre-hospital realm and we figured that it would work. But literally, there were, 3 mobile homes in the parking lot of the hospital pretty much. There was one for the doc who covered the ER, one for the anesthesiologist to cover the operating room, and then, of course, ours that, when my dad ran the ambulance. So I tell people that, my birth certificate was number 3 hospital parking lot, San Marcos, Texas. So I grew up mostly normal, not completely. And obviously my interest and passion for emergency medical services. My older brother was a firefighter paramedic. So that's really what I wanted to do. I loved the excitement of emergencies moving fast. It went very well with my ADD. So that's how I kind of ended up into emergency medical services. I was fortunate enough to grow up in a small town where the fire and EMS was still volunteer at the time. So my senior year at nighttime, I started attending EMT school. And so that, as I say, that was my first shot of the adrenaline, and that became what kind of hooked me forever. I also at this time learned I love teaching. And so almost every certification, ACLS class, CPR course, I became an instructor in, which then allowed me to be able to facilitate and help others, which ultimately has become the problem in my life now, is helping others too much. I then became a MURSE. If y'all don't know what a MURSE is, it's a male nurse. It was a unique thing in my time. I think of the 40 plus students in my nursing class, there were probably about 5 guys. So it was pretty interesting and challenging in the world. I did that at the time. Nobody in my family had really ever gone to college. There was a small private school in the town I grew up in. They had a nursing program. Really, all I wanted to be was a paramedic. So at daytime, I went to nursing school. At nighttime, I continued my EMS training. Back then, it was called the EMT Special Skills. Now it's an advanced EMT, and then ultimately led to my paramedic training. Because I wanted to be a flight nurse. I wanted to be on the helicopters. We, it's talking with Dr. Morchetti before, when you're working on the ambulance and you got the most critical patients and you can hear that helicopter coming, that help was on the way. And I really wanted to do that. It was really, really exciting for me. So I worked hard. I was 19 years old, finished nursing school, got my associate degree in nursing, was a paramedic, and went to work. And I worked constantly. I would go from the hospital to the ambulance, back to the hospital, back and forth. And that really was what I was really dedicated to. I was fortunate enough early on. I was now in my mid-20s and got selected to be a flight nurse. So here I am, mid-20s, had achieved all my goals in life. It was good. I had a job. Actually met my wife. Obviously, she wasn't my wife at the time, but she was a pediatric neonatal transport nurse. She thought I was trouble the first time she met me, and now 25 years later, she really knows that I am trouble. So she was a very good judge of character. But I was really lucky. I got selected to work for one of the busiest flight programs in the country, which was Hermann Life Flight out of Houston. At the time, we had 3 helicopters. We were running 4,000 calls in helicopter, in addition to, we would do airplane transports, pick up people all over the world, and jets. And I was 25 years old, loving life, teaching all over the country, speaking at conferences. And then one fateful morning in July of 1999, that kind of all came to a screeching halt for me. I, myself and a good friend of mine, still Sean Salter, we worked the night shift on the 16th, so it's early morning 17th. We were on Life Flight 1. It was due for a maintenance inspection routine. We took the aircraft. We dropped the patient off at Hermann about 3 o'clock in the morning. We dropped the helicopter off at the maintenance hangar. That next morning, it had its maintenance performed, and then the crew of Lynn Etheridge, who you see there, the nurse, Mac Atterbury was the paramedic there, and the pilot was John Pittman. They had done one flight. They were actually going to get fuel to go pick up a second patient when the helicopter suffered a catastrophic mechanical failure and took a dive into our fueling site south of Houston. And obviously everybody was killed. So here I am, 25 years old, had achieved all my life goals, and instantly what I thought I wanted to do forever, I didn't want to do anymore. And I shouldn't say that I didn't want to do it. I just, I was married, had a family on the way, and it really changes things. So I had a great medical director, which I'll talk about here in a second. And it was actually at Lynn's funeral. My wife and Dr. Duke, we were walking back to the cars, and he had always kind of joked and called me doc in meetings, asked me questions. Hey, doc, what would you do? And so I asked him, I said, so if I wanted to become a doctor, go to medical school, what would I have to do? And he explained the medical, the college admission test, the MCAT. He explained all the prerequisites. He explained the applications, system in Texas at the time. And so that kind of started a rapid evaluation for me. So I obviously had an associate degree in nursing, didn't have a bachelor's degree. I found out that I needed a couple more classes, registered in Houston Community College, registered for the MCAT, bought a medical MCAT book from Half Price Books. And, the following year, 2000, applied to medical school. Absolutely not thinking much about it. I guess that was fortunate for me, but got the opportunity to go to the medical school in Fort Worth. We were in Houston at the time, could have stayed there. I got accepted to medical school in California, Loma Linda, where my sister-in-law had gone. Actually, we went out and interviewed. My wife met with, she became a neonatal nurse practitioner. So she met with the neonatal group out there, and she loved it. It's, right outside. It's in, San Bernardino County, California, beautiful. I did not enjoy the interview there. So she came out saying, hey, let's move to California. And I was like, no way in hell. Let's go back home. So we actually chose to go to medical school in Fort Worth, which was home for both of ours. I was also very fortunate. My father had actually started working at the medical school in the late 70s. He was the first police chief that they hired. So I was very familiar with the osteopathic medical school. It became part of the University of North Texas Health Science Center, the UNT system in the 80s. I actually worked for the vet when I was in high school there, in their laboratory animal medicine facility. So was very, very familiar with the school and was happy to go there. I know there's a lot of questions about osteopathic medicine, so I'll briefly try to explain it at the time. The osteopathic medicine education hasn't changed. I'm sure Dr. Fowler Morchetti can probably talk more about the allopathic. But osteopathic medicine was founded by, it was an allopathic physician, an MD, who in the late 1800s got very disillusioned with traditional medicine. He had lost most of his family to pandemics and to other illnesses, and really kind of did some soul searching, became very close with some Native Americans, and learned a lot of their type of medicine. he started studying the bones of deceased people and started to find the associations between disease and the musculoskeletal system. The ultimate philosophy of osteopathic medicine is that, you know, the body has the ability to heal itself if you facilitate it and help it. There's not much from a science perspective. You know, we take the same test that MDs do. The addition is that we learn osteopathic manipulative medicine, which is a lot, Morchetti will know a lot of that is very much what traditional physical therapy would be. So everything from lymph pumps to, you know, releasing muscle tensions and a variety of things, because, you know, if you learn the embryonic development of the human species, and you start to see dermatomal, myotomal distributions, the same, you know, you think people have a heart attack have left shoulder pain, or often people that have gallstones have right shoulder pain. I mean, if you go back to the embryonic development, you'll see where all of that is kind of tied together. And so Dr. Still's, you know, belief and philosophy was that holistic approach to medicine. Early on, osteopathic physicians were traditionally non-traditional medical students. So they were older individuals who had medicine as a second profession, a second career. That has really changed. You get into the 90s and now into 2000s. In fact, the year that I applied to medical school was the first year that the Texas Osteopathic Medical School was part of the Texas Medical School application system. So it was applying to TCOM was the same as applying to UT Southwestern, UT Houston, all the other schools. In addition, I found the school very clinically focused. And so not having a big science degree like many of you are getting, having just simple a two-year nursing degree, I loved clinical medicine. And so their curriculum at the time was very, it still is, systems-based. And so we went through the various systems instead of traditional biochemistry or, you know, microbiology or more what other schools were doing at the time. It also really focused on the physical assessment pieces, a lot of hands-on. And so that's why I chose the Osteopathic Medical School. There's still the vast majority of DOs go into primary care. In fact, TCOM still to this day in Texas graduates the most primary care physicians of all the medical schools. So most graduates of TCOM go into primary care. Not a lot of specialties. There are some, obviously, but it's much smaller than other traditional medical schools. So if you have questions more about that, I'd be happy to answer them. It's, you know, historically was, I believe, a much different philosophy. I would bet nowadays there's probably a lot more holistic approach when you look at the non-clinical things of medicine. When it comes to, sorry, my phones are going off here. We're having a storm. Treating your patients, you know, what they eat, the lifestyles they live, all the non-clinical things that affect health, which we know is the vast majority of life today. The other reason I chose TCOM because it was home, and I was able to work all through medical school. So I worked for CareFlite, which is here in Dallas-Fort Worth, and was a flight nurse. I worked about a 12-hour shift a week, so about 48 hours a month. Everybody gets all excited. It's like, oh my God, how did you work through medical school? Well, the reality was I worked night shifts. And so I would study till midnight, 1 o'clock, and then I would get paid to sleep many nights. Occasionally we would have a call and I would whip out my note cards that were in my flight suit and I would reference all kind of medical things on the way to flights. So it was good for me to keep my mind sane. In addition, I found it was a great resource. So I had some great physicians that I worked with. And so I was able to ask questions. I was able to take the things that I was learning in medical school. You know, it was, for me, especially the second year medical school was much funner than the first year because I had seen these patients for 10 years, didn't really know what their problems were. And so medical school really kind of taught me, it's like, oh, that's why that guy smells like that. Or that's why, you know, the diabetic smells sweet. And that's why the, you know, the the guy with chest pain has a slow heart rate and he's pale and he looks really, really bad because he's having a heart, so it was really good for me because I had seen lots of sick people and never really knew what I knew how to treat them, but I didn't know what the hell their problem was. And so I found medical school a lot of fun. And in fact, I was years ago at a conference and met Ray, who was the astronaut that spoke a few years ago? It was Musgrave, wasn't it? But he was
I don't remember, Jeff. I'm sorry.
It was Musgrave, I think. But he was you remember Brandon?
Yeah, I know who you're talking about. I can't remember his name though. I'm sorry.
His talk was very much like me. He was an engineer who became a physician. And
it was Story Musgrave. Story? Was that who it was?
So,
one of Musgraves?
Yeah.
Anyway, go ahead.
But I love tinkering with things. And so working on engines, working on things. So to me, that's kind of what the body was. It was a big machine and everything had its purpose. And, if something was wrong with the machine, just like my car engine, I knew some way to view it as that way and view the body and view medicine and diseases as that. So that was my way.
Hey, Jeff, so was medical school impossible? Was it impossibly difficult? Or is it something that someone willing to work hard can do?
So it depends. So for me, it was a job. I did it 10 hours, 12 hours a day. I had a very supportive wife and family. Like I said, my dad worked at the school. My daughter, Darby was a year old when I started medical school. We had my son right into my second year of medical school. It was hard, but I found that if I put the time in, that I would get out of it what I put into it. As an advisor now working at the medical school, so I'm a faculty advisor for medical students. All the medical students are very smart. I mean, obviously you do well on your coursework, you do very well on your medical school admissions tests, but medical school is drinking from the fire hydrant. So it is as much of learning information as it is being able to manage stress and prioritize, because there's no way that you can learn it all. The other thing I find often with medical students is, many of you are very smart and school is not that hard for you. You make very good grades and you're just naturally intelligent. You do well on tests. And many of you are probably top of your class. And then when you get thrown into a class of 200 people that are just like you, that are very smart, that were all top of your class, instantly you become average. And that is very hard for people who have never been anything less than the top 10% to now be average. And so I see every year I have 1 to 2 medical students that just self-implode, not because they're not smart, not because they can't do the work, but they self-destruct because they can't handle the pressure. And often they fail to take use of the resources that are available to them, being counselors, being tutors, being other things, because I think for many of them, they've never had to ask for help. And so it's very hard for them to ask for help. So for me, it was a job. I remember test days when I walked up to the, board, and at the time they would put all your scores up on a sheet with your student ID number. And anytime my number was above the pass line, it was a celebration for me. In fact, I tell people all the time that, they call the guy who graduated last in my medical school class, they call him Dr. Beeson. And so it is managing life as much as it is managing medical school. I think it's very doable. It is hard work, but it's truly something that you have to want to do, because it is definitely work. Does that answer your question, Ray?
Yes, sir. Thank you.
Okay. For medical school, that was, I think residency match was probably the worst time of my life. I was married with kids. My family was here. There were places that I wanted to go for me for an experience, but there were also places that were, the best thing for my family. And fortunately, having Parkland across the street was really both. I enjoyed Parkland. I had taken patients into Parkland as a paramedic and as a flight nurse for years. I mean, it is Parkland. We refer to it as the lands. And so when I found out that I matched at Parkland, it was an exciting time for me. It was really allowed me to stay involved in the community. In fact, my first year as an intern, I still flew some shifts for CareFlite as a flight nurse, which was funny. I'd go from being a resident one day to being a nurse at night. I remember it was the first couple of months of Parkland, September, October. I flew a burn patient in from Oklahoma into Parkland. And the charge nurse at the time looked at me and says, "Man, you look just like one of our ER residents." I was like, "Really? What's his name?" He says, "I don't know." And he walked over to the sheet where all the residents, and he pointed to the picture. He says, "Jeff Beeson." I said, "Hey, looky there, Jeff Beeson. What do you know?" So it was kind of fun, and it once again kept me grounded. So when I finished residency, I took a local job at a community a hospital in Fort Worth, working in the emergency department. I had been a former paramedic at MedStar. Obviously, Dr. Fowler was working there, Dr. Griswold, the medical director at the time. I got an early opportunity in my career to be an associate medical director and to work particularly with the fire departments in Fort Worth and the surrounding areas. So that led really, once again, just like my nursing career, early on in my career, a couple years out of residency, I became the medical director in Fort Worth. So clinically, I was fine. I knew, how to practice medicine, how to work with paramedics. The one thing I didn't learn is politics. And so it was a very learning, growing experience for me to be in Fort Worth. In addition, some of the other jobs I'll talk about in a second, they're in the middle. As I went to Evolution Health, I really found a passion for healthcare delivery and system design, and got the opportunity in 2014 to 16 to work with a great group doing population health. My EMS background, I ran our medical command centers. We had one in Dallas and one in Fort Worth and in Miami, Florida. And that was nurse centers. I got to develop nursing triage protocols that are still in use today in 911 centers to help navigate patients. We did remote patient monitoring. We had pharmacists working in there. It was a great opportunity for me to learn healthcare design and system delivery. And then 2010, I joined the task force, which will primarily what we'll talk about tonight is disaster medicine, which I love doing. So what I did too is my service. I started getting on all these boards. So when I was a medical student, obviously a member of the Emergency Medicine Residents Association, they call it EMRA, got elected as a medical student representative. And of course, then the relationships that came from that into the American College of Emergency Physicians. Their EMS liaison, believe it or not, Rick Murray, who still works for ASEP, was my paramedic instructor who used to work on the ambulance with my father. So I started getting calls from ASEP. "Hey, we got a special project in Vegas. Can you do this? Can you do that?" So was always willing and ready to help, which opened a lot of doors for me.
Hey, Basin.
Yep.
You didn't really spend much time talking about your experience back in Fort Worth. For the listeners here, here's Beeson, the ultimate and non-traditional person who starts life as an EMT, becomes a paramedic in Fort Worth, and then a flight nurse, and then goes to medical school, and then goes to emergency medicine residency, and then goes back to Fort Worth to take over being the medical director of the very service where he started. You talk about full circle, hometown boy comes home. And I know it happened because I was there the day that we voted on him to make him the medical director. So you didn't touch on that very much, but the full circle,
Yeah, it was. And I'll talk about it in a little bit, kind of how I ended up where I am. From being the EMT to being the nurse to being the physician, it really has allowed me to see the whole, nice thunder there. The entire circle of healthcare delivery, from pre-hospital to hospital, back out into the pre-hospital realm again. And in the next slide, Ray, I'll kind of talk about that briefly. So I also then got on, the governor here in Texas has an EMS and Trauma Advisory Council. So I initially was on the Medical Directors Committee, became the chair of the Medical Directors Committee, and then was appointed by Governor Perry as the medical director on the actual council. Served my time there. In addition, the National Association of EMS Physicians, I joined their board, was elected to 2 cycles, and now I'm actually rotated off, and then I'm back on currently again as a member at large. And then got really involved in we have a 501c3 charitable organization in Texas called the Texas EMS Trauma Acute Care Foundation. I joined their board of directors, and we really get to advocate and work on projects to improve trauma acute care delivery across the state of Texas. So I found board service for me. Not only did I learn more about systems, but I also met a lot of people from across the country that then have ended up allowing me to open doors, call upon friends and colleagues, which is, I think, probably made me one of the more marketable, or made me more marketable in what I'm doing today. So to what Ray's talking about there, in 2012, I was invited by a group. We met in Chicago to talk about really the problems in healthcare delivery. And so what we had found was an EMS. When you call your doctor's office, the recording says, if you think you have an emergency, call 911. Well, most people don't know if they have an emergency or not. And so they do exactly what the recording says. They call 911. So we respond lights and sirens to people's homes that really don't have emergencies, but they don't know what else to do. In addition to people who get discharged from the hospital, the last thing the nurses tell them upon discharge is, if you have any problems, call 911, which is exactly what people do. And, you find out when you respond to their home that they just got discharged from the hospital. And so we take them right back. So hospitals started getting under all this pressure about readmission rates, the lack of primary care. And so as we met, we were all EMS physicians. And we said, listen, we have a huge workforce. We respond to millions of calls every day across the United States, medical calls, not all emergencies, but unfortunately our systems are only designed to pick people up and take them to the hospital. In fact, EMS in this country resides in the National Highway Transportation and Safety Administration. So NHTSA is where EMS lives. EMS is paid to transport people to hospitals, not deliver care, to transport. So in many cases, EMS is a transport benefit, not a medical benefit. And so we really developed the concept approach of mobile integrated healthcare. And how does EMS get at the table? And so from there, you started seeing a lot of moves to more population health, community paramedicine, a lot of non-traditional delivery systems. As hospitals close across the country, the only healthcare that exists in many communities is EMS. And so we said, how could we, do this and, benefit those communities? And so that concept of mobile integrated healthcare really started opening a lot of doors for what I did, both at MedStar and then when I worked for Acadian Ambulance, working all across Texas, and then Evolution Health, as I told you, I ran the medical command centers. Ray mentioned this briefly. I've also been very fortunate to speak a lot on the mobile integrated healthcare concepts, both locally and internationally. I was fortunate enough to go to Cuba before Cuba had opened, before it closed again. That's me on the bottom left there at the Port of Havana telling all the Texans, come on down, the water's good. The middle two pictures, I got to go to Russia, St. Petersburg, Russia, and visit their system, which is very interesting. The bottom center picture there, you see that is a cardiologist. They actually have physicians on their ambulances in Russia. They have a different system design than we have. And then the two right pictures, I was invited to Australia a few years ago to speak. So it's really been good for me. In the middle of all this talking and traveling, I'm also continuing to learn. I learned a lot of things, believe it or not, in Cuba, a lot of things in Russia and how their delivery systems are in Australia. In addition to that, got to participate. President Bush 43 actually is a big fan of the Wounded Warrior Project, supporting them. That's my boss, former boss at Acadian Ambulance on the right side there, who was a big supporter too. So a couple of years got to participate with the Wounded Warrior Ride in providing medical services. Bush looks happy because he rides bikes all the time. I don't. I just rode 40 miles and my butt hurts. That's why I look kind of weird. I will tell you a plug here. I don't even have a Trek, but I'll tell you, both years I participated, this is the first year Trek came out. Those are like $5,000 bikes, and Trek worked with a prosthetics group. All of these Wounded Warriors have missing limbs, and so they created prosthetics and then custom fitted the bikes for all the Wounded Warriors, and then gave them the bikes after the weekend. So I don't own a Trek, but if I were to buy a bike, I'd definitely buy a Trek because they were very supportive of the Wounded Warrior Project. So I appreciate that. I was also very fortunate. I was, invited to the White House. Here I am in the White House Medical Unit. I was consulted, believe it or not, it was a very interesting consult. It wasn't a difficult patient or anything like that. This is one of the physician's assistants that works with a colleague of Ray Fowler's and mine, Ronnie Jackson, who was the head of the White House Medical Unit. She really wanted to know what was real barbecue. Was it beef or was it pork? And I, of course, I'm from Texas. It's beef. I mean, there's no other way it could be. So I was able to set the White House Medical Unit straight and let them know that true barbecue is beef, right? I mean, you look at the ribs, they're a real rib, right? I got good friends in Tennessee, but those little bitty things aren't ribs, all right? That's a pig, that's a cow. So barbecue. Currently, on top of working at the university, I also joined Global Medical Response back in June, as their Associate Chief Medical Officer. So Global Medical Response is the largest medical transportation company. We've got about 38,000 employees, transport millions of people every year, both air, ground. We have fire support. And the main reason I got recruited to GMR was that CMS has a new innovation project called ET3, which is emergency triage, treatment, and transport. So finally, CMS is going to pay EMS to not transport people to the emergency department. And so Ray will support my thing here. About 30% of 911 calls end up in no transport. So the individual calling 911 doesn't have emergency, but doesn't know it until the paramedics, EMTs, and paramedics arrive.
Well, the old way of paying also sent a very odd message, namely, you only got paid for being involved with patients if you transported them, which means you would make all these runs and not transport anybody. And so it really pushed agencies to transport people to the hospital who might not really need to go to the hospital. That's another whole issue of its own.
True, very true. So under the Innovation Grant, 200 services were awarded ET3 pilot projects, and Global Medical Response was awarded about 65 of those. So that's, that's primarily what I'm working on, but we have this COVID thing, which has also thrown a wrench into everything we're doing now, as you can imagine. In addition to GMR, we're also the FEMA ambulance contract holder. So we have, since March, it's been nonstop. We've had 300 ambulances in New York and New Jersey supporting COVID response there. We currently have ambulances deployed on the West Coast in support of the firefighting missions. In fact, we have an air medical helicopter that's actually has a water bucket who's also dumping water on fires in California, believe it or not. And we also have we've had for the last month about 50 ambulances here in South Texas down around the border supporting those communities in a COVID response. Traditionally, our responses for FEMA contracts have been natural disasters, fires, hurricanes, tornadoes. This year, COVID's kind of changed the ball game for everybody, as you can imagine. Funny enough, not this last weekend, but weekend before that, we were at the Indy 500. So Global Medical Response also supplies medical and crash rescue teams to NASCAR and Indy. We work closely with Roger Penske and his group. They really wanted fans at NASCAR. And so I got to work with our Chief Medical Officer, Ed Rock there. He's in the middle with me. We had screening tools. We had blocked off seats so that people were physically distanced. We had on-site COVID testing. We had all things set up. And ultimately the decision was to not have fans, but they still wanted to run the race. So that corner, interesting enough, there where Dr. Rock and I are standing, that's corner 3 right outside the snake pit, if you're familiar with Indianapolis Motor Speedway. And in a normal race, there would be 30,000+ people on that corner going into corner 3 there. And it was pretty weird to participate in the race and nobody was there. It was kind of an eerie feeling. But funny enough, as I'm sitting here on this corner with Dr. Rock, my phone starts going off because the governor has activated our FEMA team here in Texas in preparation for the Laura storm that came. And currently right now in GMR, we have about 200 assets in Louisiana. These are some pictures taken in the last couple of days of our teams that are there in Louisiana supporting the hurricane response to there. So for me, it's now, as Ray said, a complete circle. I'm still a paramedic. I keep my license up. I'm still a registered nurse. I'm a licensed physician. I give myself orders. I argue with myself, and I'm usually right. And my wife said I could say that. She's in the next room, so she said I could be right now.
So Beeson, let me get this straight. You've got one voice in you that's in an EMT, and another voice in your head that's a paramedic, and another voice in your head that's an emergency nurse, another voice that's a flight nurse, another voice that is a physician, an emergency physician, and another voice who's an administrator and a medical school official. I mean, what do you do with all those voices in your head?
Lots of medications. Lots of medications. Not that they work very well, but lots of medications. So I say that, and I use this slide a lot with folks. How do you see the world? I mean, you're obviously interested, thousands of you on the line here, you're interested in medicine. But how do you see medicine? What is medicine to you? Is it a job? Is it a life calling? Is it a profession? Is it a fad? I mean, I think that we all see the world differently. And I like this picture because your background, where you grew up, how you were raised, is how you see things. So some of you see this picture and you see a young lady who's looking off to her left. You see the silhouette, or the shadow of her nose. You see the curvature of her jawbone, wearing a necklace. But others see an older lady who's looking forward and to her left, where you see the eye and you see the nose with, a mole or a growth on it. And so some of you see both. And I think that when you get into whatever chosen career, if you choose to be a physician's assistant, a pharmacist, a physical therapist, a nurse, an EMT, it really doesn't matter. But you have to enjoy what you do, and you have to believe that you're making a difference. That's one of the main reasons I got into more of administration and healthcare delivery processes, because as an emergency physician, I could help, the one person at a time that I was taking care of. And when I get into system design and I get into adjusting the future of how healthcare is delivered, I get to affect thousands of people every day. And although that is stressful, in many ways is not as rewarding as taking care of patients and seeing the outcomes. But I also believe that many of us plant trees in life whose shade that we know we're never going to sit under. It's really for the next generation, for my daughter and those who come after me to make it better. I was fortunate enough that I had some great mentors, and they always had good sayings. Dr. Duke was the medical director when I was at LifeFlight in Houston. In fact, he wrote a very nice letter for me when I interviewed for medical school. All my interviews for medical schools, they wanted to talk more about what it was like to work with Dr. Duke than me. They didn't really care about me. They wanted to know what it was like to work with Dr. Duke, because he was very famous. He was actually a resident at Parkland in Dallas in surgery when Kennedy came and shot, and actually was able to recognize the governor, Conley, that was shot. He put a chest tube in Conley and took him to the operating room, and they became lifelong friends. He actually started the LifeFlight program in Houston in the 70s, which I got the opportunity to work for. He was a great mentor, said many great things, but one of his sayings, he's obviously passed now, but was always that we have to remember that we don't save lives. We are entertaining this physical body while God decides what he wants to do. And I think that's really been helpful, because I've had people through the years where I do everything right and they die. I've had people that I have screwed everything up and they live in spite of me. I also had a great mentor, Ray, there on the right, in his younger, good-looking days. Not that he's not good-looking now, but he has a different hairstyle. Is that, the things that the eyes will not see, what the mind does not know. We look, but we don't see. And most importantly, always explain tachycardia. Right, Ray?
Absolutely.
Always explain tachycardia. But I think, medicine is obviously a lifestyle. It is a life calling. It is a career. It is a passion. It is more than just a job if you choose to do it. I often listen to wise philosophers like Master Oogway from Kung Fu Panda, who said that, yesterday is history, tomorrow is a mystery, but today is a gift. That is why it is called the present, right? Master Oogway, the wise philosopher. So before I get into the disaster medicine piece of it, I figured that this is probably a good break point if you facilitators want to ask some questions.
Jeff, we got a bunch. We got 24 already that have been fired at us. Did you face anything different as a DO rather than an MD? Has it mattered to you, or do you care?
So I will tell you that it is, there are still a lot of programs that look at you as an inferior physician. In fact, Southwestern was well known for that because emergency medicine was a division of surgery at the time. And a very famous surgeon was not a fan of osteopathic physicians. After he passed, the next year, Southwestern let their first DO residents in. So I was the third class of residents that DOs that ever got into Parkland. There are still a lot of programs. In fact, it's funny. I applied to emergency medicine in Loma Linda, where I was accepted to their medical school but didn't go. Their chief resident was a nurse who I precepted here in Texas, so I knew him well. And he told me, he says, we're not going to interview you. We don't interview DOs. Denver General. So it's interesting. If you're a medical student and you want to do a fourth-year rotation in Denver General, they charge allopathics a few $100s for the application. They charge DOs thousands of dollars to apply for doing a fourth-year student rotation there. So there is definitely doors that will close if you choose to go to an osteopathic physician route. But I think that those are decreasing. A few years ago now, we did have osteopathic and allopathic residencies. They're all combined now. But it is definitely, you got an uphill battle if you want to go, especially into some specialty surgical subspecialties. Now, we do it all the time. We have students at our school at TCOM who score in the high 90th percentile on the USMLE test, the same test the allopathics take. We have to take the osteopathic board exams. We don't have to take the allopathic board exams. So it's COMLEX for osteopathic. It's the USMLE for the allopathic, the MDs. Most of us take both tests. And so not all, but most of us take both tests so that we, when I'm like Southwestern, when I applied to Southwestern, that they knew that I was competitive, just as competitive as an MD student. But my fellow DO, my year, he didn't take USMLE. He only took COMLEX, and he still was able to match at Southwestern. So there are some challenges. But most of us that choose, when I started medical school, man, I was going to be a small town family practice doc. I was gonna drive my little Porsche Speedster like Doc Hollywood and then crash into the judge's fence, and I was gonna take care of toes for pigs. That's what I wanted to do. It didn't work out that way, and I'm glad it didn't work out that way. But when I went to medical school, that's what I wanted to do, and I knew that an osteopathic medical school would prepare me for that kind of practice environment from birth to grave. So that's kind of where I chose the osteopathic route.
Okay, on a different question, how did your EMS experience contribute to your physician experience, Jeff?
So the first year, it did not whatsoever. And remember, I went to medical school with an associate degree in nursing. I didn't have a lot of those bios and chems and all that kind of stuff because at the time they weren't required. I had to have general chemistry, organic chemistry, physics, and biology, and that's about all that I had. So the first year was a real struggle for me. My saving grace was we had a system-based curriculum, so all the science was mixed with anatomy and physiology. And in high school, I worked in the medical examiner's office and did autopsies, so I was good with anatomy. I knew anatomy up one side down. Didn't know jack about the Krebs cycle, but by God, I could identify the phrenic nerve in no time. And so it was a balance for me. Now, when we got to the second year, which was really diseases and management, I had seen those people for 10 years, so I knew what they looked like. I just didn't know what the problems were. So it was really fun for me to learn what was causing them to look like and smell like what I had seen for 10 years. Now, when I got to the clinical years, I really had to play dumb because there was nothing worse than having a second and third year resident, showed up by a third year medical student. So I quickly realized to play dumb that I know nothing. Will you please, sir, show me how to start an IV because I've never done it before in my life. And it allowed me to learn to play the game well. And, I, like Nike says, I just did it. I didn't know anything, but I did. And so third and fourth year was really easy for me. I mean, the clinical stuff was really easy. And then when I got to residency, actually, Ray, you told me this, right? You're going to score high the first year. We take these, what they call shelf exams every year, which is kind of like your board exams. So the first year I was way ahead of my class. The second year, I didn't score any higher than the first year. My class caught up with me. The third year, I scored exactly like I did the first year. My class passed me by because I quit learning. They continued to learn. And so they're much smarter than I was. And so that's kind of how it helped me and then ended up hurting me in the end.
So Jeff, about your college background, you did some community college, right? Do you think a community college, early in college experience helps or hurts about applying to medical school, or what do you think, or do you have an opinion on that?
So, I'm not involved in our medical school admission, but I can tell you from folks that I work with, it really comes down to, unfortunately, entrance exams. So your MCAT score is really the first thing, because you can have a 4.0 GPA, and if you don't score well in the MCAT, they're less likely to look at you. And so it's not fair. It just is what it is. I do know that schools have rankings that, if you got a 4.0 at Houston Community College, it's probably equivalent to a 2.5 at A&M or Tech or something like that. But to be honest with you, if you do well in your MCAT, where you got your degree from really doesn't matter. I mean, I scored average on my MCAT. Fortunately, I was very strong in sciences. So at the time, there were 3 sections. There was biological, physical sciences, and then English. So I didn't even have biology when I took it. And I scored, the 80th percentile on my sciences. Now I scored 20th percentile on my English, but I'm from Texas. So I didn't think that was a fair test. I felt that I was not evaluated fairly. So the English did hurt me, but fortunately I made up for it in the sciences. So that's the reality of it. But, I have a slide at the end, and I have a lot of good friends who got bachelor's degrees from very good schools, applied to medical school, and didn't get in and were devastated and quit. They didn't try again. They went on to other careers, and they've been successful. One's a CRNA, one's a battalion chief at a fire department here in Dallas-Fort Worth area. But I think it comes down to, if you want to go to medical school, you want to be a physician, then you do it. I mean, even if you don't get in the first time, if you need to get a master's degree, if you need to go to, almost all medical schools have a medical science, master's program, to where it's really like the first year of medical school. Go get your master's in science and prove to them that you want to be there and that you're just as smart as the next person is. So that's the hard part about it.
Do you think the med school you attend matters much when you apply for a residency program later?
I think it does, especially if you wanted to go into some highly competitive specialties. I can tell you, I have, even as an osteopathic physician, I probably had 1 or 2 people in 10 plus years ask me, what's that DO on your name tag? Most people don't care. They don't know the difference. They don't care. They don't care if I graduated last time in medical school class, first medical school. They didn't care where I went to residency. I mean, I think in some cases it matters. Now, if I wanted to be a retinal ophthalmology surgeon, it probably mattered. If I want to be a general family practice or a pediatrician, or an internal medicine doc, no, I don't think it matters.
So a couple of personal questions. One is, was it tough having a family when you were in med school?
I actually found it more balancing. So I didn't have to worry about, people liking me. She married me. She didn't have to like me anymore. I didn't have to worry about, dating or, making my parents happy that I'm going to find a wife or what, I didn't have that. To me, it was a job. I wasn't trying to prove anything to anybody. It wasn't like, I have medical students, honestly, who, they were in high school, very smart, and their teachers like, oh, you need to go to medical school. So they do. They go to medical school, and they struggle through medical school, and they hate medicine. But they never had the nerve to tell their parents, this is not what I want to do. And so they have been forced into, it's almost like an arranged marriage, right? They're going to something they don't want to do, but they don't want to hurt their families. And so I wasn't like that. I mean, I finished college. Nobody in my family had done that at the time. So, I mean, I could be a loser and my parents would still be proud of me. So I did my time. We were fortunate enough. I bought an older house right near the school so that we remodeled. So literally it was 2 blocks away from school. So I was able to, get up in the morning, see my family, go to work. My wife worked as a nurse practitioner in town. Like I said, our families both lived by. So her mother had retired from the school district and was able to babysit. And we had 2, obviously, my second year. I really think it balanced me, and it kind of reminded me of why I was doing what I was doing. I had a good friend in medical school. You find, partners and friends that you study with. And so I had a friend named Reagan, actually, who came and studied all the time. And so my daughter Darby was young. And so every night she went to bed, Reagan was upstairs studying with me in the office. And so she would wake up and go to the base of the stairs and yell, "Reagan, wake up, come down for breakfast." And I was like, "Honey, Reagan doesn't live here." But to Darby, every night she went to bed, Reagan was upstairs studying with me. And so you just find a way to balance it and realize that you're not going to learn everything. You're not going to be top of your class. Some of you will be, but most of you will not be. And do you enjoy what you do? And do you feel like you're making a difference?
Last question before we move to the next section. So Beeson, are you really ADHD? And if so, how do you deal with it?
Yeah, fortunately, you can only see about this much of my house. Yeah, I really am. I love taking on projects. I have a problem finishing them. I really didn't know that I had ADD. Looking back now, it makes sense. In fact, it was my son was in elementary school, and the teacher came and was concerned. He was making straight A's, but she was concerned and wanted to hold him back, because she went through all this stuff. The counselor was there, and they named off all this stuff. I was like, yeah, so what? I got that. So, and then the counselor was like, well, I'm concerned he has ADD. I'm like, nah, he doesn't have ADD. And my wife looks at me and she's like, you have ADD, dummy. I was like, oh, I do. I didn't know that. I guess that makes sense. I'm functional. I do have a hard time concentrating and finishing things, but I've been very fortunate in jobs where I can balance multiple things simultaneously. So I'm a very functional ADD person.
Jeff, I do have one more question, and it's kind of a tender question. You and I both had a mutual friend who passed away, Mike, who became a mentor of yours, and he did also for me when I came here 20 years ago. He's since slipped away from us, but he affected your life at an important time of transition about helping you find your path. Could you comment a point or two about Mike and how he affected you?
Which Mike?
Wayne Scott.
Wayne Scott, yeah. So I actually had a somewhat different relationship. I mean, I respected Wayne Scott. He was never really a big fan of mine. He was supportive of me, well respected. He actually gave me a hard time my first year about flying as a nurse. He tried to tell me I couldn't do that. And but later on, I was fortunate enough to be able to care for him a couple times during his illness, and had a heart of gold. And I really think that he wanted the best for everybody. I was probably one of the most non-traditional people he had ever seen. I wasn't his mold of what his traditional residents were, but it grew into a great mutual respect, and I think that we all have to have those people. We don't always have to agree with people. I mean, if you surround yourself with people just like you, that becomes a cult. I mean, you got to have people that are different from you, that have different backgrounds, and it's okay sometimes to agree to disagree. But and that was the relationship that I had with Wayne Scott. So it was a great man. Obviously, he let me into residency, so he took a heck of a chance. Sure glad it mostly worked out for him.
I just finished the first half of my career. I was 47, and I came to Parkland, and there were these kids half my age on call for surgery, and I'd put the call in for them to come down, and they'd come in and tell me what was wrong with the patient, and I was infuriated that I couldn't help plot the path for the patient. And I said, Mike, what am I supposed to do about that? And he said, just say to them, just do it for me. That was some great advice. Anyway, take it away.
All right. So let's jump back into disaster medicine. So 2010, I was, in emergency medicine, really had an interest in disaster medicine. So I started doing some research. So for you to understand, in our country here, the Department of Homeland Security runs really functions of responses. So these 15 emergency support functions are the response system that exists in our country. So currently, obviously, we just had Hurricane Laura. So these things are ongoing. So if you look at ESF1, which is transportation, well, that's obviously run by the Department of Transportation. How do you get the roads open? How do you move people? ESF4, firefighting. ESF6 is mass care and housing. So human services, you think about large shelters when you're moving evacuees and things like that. So I was first interested in ESF8, which is public health and medical services, which is under the Department of Health and Human Services, HHS. And I got a slide here that talks about it briefly. They're called DMAT, so Disaster Medical Assistance Teams. And so I was really in the process of joining a DMAT. There's multiple DMATs in every state, and it's an application selection process. But in a sense, they're portable hospitals. You got doctors, you got nurses, pharmacists, therapists, X-ray. I mean, you got what you would have in a hospital, and they are mobile. They move. They're able to rapidly set up. And so that was the route I was going. And then there was an ER doc that worked at JPS that asked me, he says, man, you ever thought about joining the search and rescue team? And I was like, what is that? I don't know. So he started telling me about ESF9, which is search and rescue. And I interviewed for the search and rescue team, was selected to be one of their physicians. And it's really become a second family to me. And that's primarily what I'm going to talk about now. So you may hear about later about, what is the, Department of Homeland Security's, 15 divisions of operations, and it would be the emergency support functions, or ESFs. So when you look at disaster response, there is a national incident management system. And this is how it is almost like a different language, but it's the commonality of how we respond in this country to disasters. So everything, the actual NIMS, thought process development actually came from wildland firefighting. So if you can imagine the fires in California, it's not like fighting a house fire. You have multiple fires going on simultaneously. So how do you manage a large incident? And that's what NIMS is. And so I put this slide up here to tell you all that, regardless of what you go into, the FEMA ICS training courses, Incident Command Structure, ICS, all the 1, 2, 7, 8s, they're all free. They're all online. It maybe takes you a couple hours to do them all. But I think, most of our programs at the Health Science Center Fort Worth actually require students to do this. And it's very applicable now. When you see the ongoing pandemic, it's really an incident, and it's being managed with incident commanders and other things. So when you look at the system of management, it's the National Incident Management System. When you look at the organizational structure of the incident, this is where incident command structure comes in. And so this is primarily so you know what area or section that you live in, and you know who you report to. So you only report to one person. This goes into the span of control. And it's a very organized way of managing large incidents. And this is used in the fire service today. If Dallas Fire Department were to have a fire, and they would have multiple stations, multiple engine companies, everybody coming, there would be the incident commander, which would be the battalion chief. You would have the safety officer, there's a public information officer. You would have all of these sections that kind of come, not all of them, but this is the way it works. So in USAR, this is how we live. Medical is actually under the operations section. But when you talk and when you learn, incident command is what's the world we're talking today. In fact, when this pandemic first started, I actually went up, a colleague of mine is a chief operating officer of a large healthcare system in Ohio, and he's an emergency physician like us. And so he actually said, Beeson, I need help. I'm trying to institute incident command into a hospital, and I have all hospital CEOs. They all want to be incident commanders, and they can't be. I need you to come up and help me put people in seats. So not as a hospital, but as a healthcare system, we can manage and operate. And I'll tell you, of the healthcare systems that were back and operational, they were the first. They have done so well in this pandemic in maintaining normal business operations, screening patients, testing people. And so I'll tell you, wherever you go to in healthcare or in any public safety, learn the incident command structures. So if I get over here to this slide, so this is ESF 8. So this is the DMAT I told you about what I was going to do. This is traditional healthcare delivery. So physicians, nurses, hospitals that live in this, and they're a self-contained unit. They bring everything from a pharmacy in to x-ray machines to everything. We are fortunate in Texas that we started this process mimicking what the federal response was. And so in Texas, we actually have the emergency medical task forces. And so this is another opportunity. A lot of states have similar ESF8 state level things. So we have emergency medical task forces in Texas that are regionalized and partner with hospitals, staff from nursing room, from nursing, from emergency departments, from all kinds of stuff, participate in disasters. The EMTF for Texas is just like this. This picture here on the left kind of shows that this is one of the mobile medical units that actually was activated just this last week in Laura. They're set up in Beaumont, Port Arthur, because the hospitals are frequently overwhelmed. They lose power. So the mobile medical units can come in and set up, emergency care, longer term care. There's even the possibility of some of the surgery suites being set up, and it's all self-contained. And so I enjoy that non-controlled environment. In addition, we've really focused in Texas on these ambulance buses or multiple patient vehicles, MPVs. We have them strategically placed throughout Texas. So when Laura started coming in, the governor activates an emergency in Texas, and these multiple patient vehicles start to evacuate nursing homes and hospitals before the storm ever comes ashore. So that's kind of the concept. In addition, our regions, we also are very in Texas lucky to have resources like this is a screenshot of the EM resources. So I was deployed on Laura in an incident support role, working with both federal teams and our local state teams. And I could literally, pull this web-based up. I could go to different regions of Texas and I could know what's the status of hospitals. Are they open? Are they on generator power? Are they evacuating? I could see the EMS systems. I could see the air medical systems. And so having surveillance of all the things that are going on are very important when managing a large disasters. Now, people often ask, why does it take so long? Why did it take 3 days for help to get to New Orleans after Katrina? Well, that all is based upon the Stafford Act. And so there has to be an emergency, obviously a flood, a hurricane, others. There has to be unmet needs, and the state has to ask for help. So the feds cannot deploy a federal team to actually engage and start working unless the governor has asked the president for help. And then here's Laura, we just went through last week. So the governor of Texas declared an emergency, and he asked the president to declare an emergency. He asked the governor of Texas, asked for federal help. So Trump declared an emergency for Laura, federal emergency for Texas, and so federal resources were dispatched to Texas. The Louisiana governor did not ask for help. So they had their own internal state disaster declaration, but they did not ask for a federal declaration. So in Texas, we had been strategically placed in search and rescue teams. We had ambulance strike teams. We were evacuating the Gulf Coast. They weren't in Louisiana. They finally declared or asked the president to declare a disaster a few hours before the storm came ashore. Well, it traditionally takes 24 to 48 hours for those resources to get there. So here we are, 2 to 3 days after the storm, and the resources are now starting to show up. So that Stafford Act really is the declination of a disaster. And so we will now, sometimes the president will, even without, the president will declare a disaster and start moving federal assets. So many hurricanes I've been deployed on, especially in Florida and on the East Coast, we're there, but the state has not declared a disaster. The state has not asked for help. So we can sit there. We are a federal asset to help, but we cannot engage and start doing search and rescue until the governor of that state, actually it's a local city politician, county politician who asks the governor for help, and then the governor asks the president for help. So that kind of prevents the feds from coming in and taking over, if you want to look at it that way. But the Stafford Act is how it exists. So in Texas, we're fortunate enough that we have 2 teams under ESF 9. So we have Texas 1, which is based out of College Station, Texas 2, which is based out of Dallas. Now, both teams can be called upon the governor of Texas. Like this LOR deployment, we were a state asset. The governor can call us up. Texas 1 is also one of the 30 plus FEMA teams. So we can either go out on a federal deployment or on a state deployment. Now, the only way Texas 2 can go out of the state of Texas is if a governor of another state like Louisiana were to ask the governor of Texas for help, and the governor then releases his resources or her resources to go help another state. And that happens quite frequently. We have water squads under a state-to-state agreement. So our swift water teams will go and help out the East Coast. And it's not under a federal order, it's under a state-to-state agreement. So that's kind of how that works. So who is Texas Task Force? It's really a complex structure. We're part of the Texas A&M system. Many of you are probably Aggie students. So the A&M University system has the engineering extension, so TEACS. TEACS partners with the Department of Emergency Management of Texas, so TDEM, and FEMA. And so this kind of slide shows it. On the left-hand slide, that is the A&M system, all the campuses that exist in the A&M system. TEACS is like one of those campuses. So TEACS is where the day-to-day operation of the Texas Task Force lives in Texas. In some states, it lives within a large, so LA City has a team. LA County also has a team. So the city of Miami has a team. Miami-Dade County also has a team. So in California has 7 or 9 teams. Now only 2 of those are federal. The rest are state teams. Florida has 2 federal teams and about 6 total teams. So it varies from state to state. But we are a state asset if we're called up by the governor, or we're a federal asset if called up by FEMA under an approval from the President of the United States.
Beeson, is that because A&M is the land grant university in Texas? I don't know the answer to that. Do you?
When we get to the background of how TEACS started, the actual organization of the task force actually started at Texas A&M through TEACS. So the fire training school, so the state fire training campus is also on TEACS. The Texas Forestry Service is under TEACS. The Texas Fire Municipality, TIFMAS, is under TEACS. So it just became, when you look at all emergency management coordination, TEACS trains all of your county in Texas, all of the county officials on emergency management, emergency response. And in fact, that was one of the findings after the Harvey recovery, was that the Department of Emergency Management sat under the Department of Public Safety under the governor, but everything else sat under TEACS, under the A&M system. So the governor actually moved the Department of Emergency Management to the A&M system now, trying to coordinate both the training, so preparation, the response, and then, of course, now the recovery piece. So I think it, Ray, has more to do with the way the system is designed through the years more than anything else. So the day-to-day operations under the state, so Texas Task Force lives under TEACS. When we're on a state deployment, obviously the governor through the Texas Department of Emergency Management, whose chief is Nim Kidd, obviously we'll call up the Texas Task Force 1 or 2. On a federal deployment, the president activates Homeland Security, who then asks FEMA to call up the ESF 9 or search and rescue resources. So that's how the federal side works. Why did they start? Well, we learned in '89 in San Francisco that when you start talking about structural collapse, that most cities are not prepared for a large structural collapse. So, when you got buildings and roadways collapsing like this, and it's not like one building collapse, we're talking about an entire city. It's not like fighting a fire. And so that's where kind of the concept of an urban search and rescue team originated from. It really came to light after the Oklahoma City bombing, when, there was a search and rescue response needed, but we didn't have one. Local municipalities, the Oklahoma City Fire Department had a technical rescue team, but, we're talking 5 guys, not 500 guys. And so the capabilities were very limited. So the Oklahoma City bombing is really the catalyst for the search and rescue world. So, and y'all also might not know, but there was only one person that was killed in Oklahoma City after the bomb was detonated. Obviously, people died from injuries, but there was one injury after the actual bomb was detonated. And that was a healthcare worker from a local hospital down the street who came to help and was in the front of this building when a large piece of concrete fell off above and came down and hit them. And so, when we talk about disaster response, you really have to think about safety. And I think in healthcare workers, we want to go in and help and save people, but you really have to take a step back and really focus on the safety aspects of it to take care of yourself. So how did Texas get Texas Task Force 1? So obviously in 95, the MURSE building, there was the FEMA system was being developed under the Search and Rescue ESF 9. But it was really the state or the local municipality would ask FEMA, say, listen, I have a search and rescue team. Will you approve me? And so that's what Texas did through TEEKs like Dr. Feller just said. So February 14, 1997, the team was formed. And in 2001, so you can see the delay, how long it took to prepare all of this, Texas Task Force was recognized by FEMA as one of the teams or the country's search and rescue teams. So Task Force 1, we have about 600 members, and that's from 60 different organizations, mostly firefighters. We have doctors, nurses. We have structural engineers, believe it or not. If you think about structural collapse, how do you know what's safe to go into and not to go into? So we actually have structural engineers that will look at a building and say, not safe, or work with our rescue guys, building cribbing and other things to shore up a building so it's safe to enter and to do search and rescue. There is an application process for folks. So for instance, every year I interview new doctors that want to get on the team. And we go through a process because it's a unique world. It's not like working in the emergency department. It's not glamour. You're not going to sleep at the Ritz-Carlton. I guarantee you that. We collectively have about 28,000 hours of training when you look at the teams a year. Each member is probably around 90 to 100 hours. And that's regional training, specific skill sets, so medical skills training. On top of, we have full-scale annual exercises where we will go on a deployment and do a 3-day exercise. And it varies. So FEMA puts out the exercises every year, and it will be structural collapse. Lately, it's been chemical and biological. So those are the things that we've been working through for FEMA for the last couple of years. We're also fortunate enough at the Texas A&M system under TEEKs to have the fire training in Disaster City. So we have a world-renowned it's truly a disaster city. It's 52 acres of training facility where it was solely designed for training. So we have collapsed buildings, we have train cars, we have hazardous materials, we have all kinds of things where you can run large scale simulations, like a hurricane came through, an explosion just happened, and really help train people. In fact, we run not only the medical training programs here, we do the structural, the rescue, all different specialties get training here at Disaster City. It's really a great place to train, to work with some of the best experts in the world. The buildings are also designed with these breach holes. So all buildings can, the rescue guys can literally, blow holes, break through these concrete walls, and they're designed to be replaced. So you see the metal brackets, they'll unbolt them and put a new breaching panel in there for training purposes. This is actually what we call a clean breach. And so it takes much more time. You'll see the top left corner there, they're drilling a hole. That's the technical search guy. So after that hole is drilled, we're able to stick cameras and stuff inside and look and see what's in there. So traditionally, how kind of a rescue, you go around yelling anybody in there. The dogs, we have search and rescue dogs that we'll talk about in a second. They may get a hit on a building. We have devices that we can set in various locations that will listen. So we have technical search guys that will listen. You'll ask a question. So from a medical perspective, it's kind of exciting, right? I'm going to test your ability to your cognitive ability. So can you hear me? If so, tap 3 times, right? So not just tap, but tap 3 times. So I know if you tap, you hear me, but you may not comprehend what I'm saying. So you have a lower level of consciousness than a person who can tap 3 times, and I can start to have yes, no, close-ended conversations with them. So in a clean breach, they have to cut through the wall because the victim may be right on the other side of that wall. I can't just bust through that wall with jackhammers because all the debris is going to fall onto the victim. So a clean breach takes a lot more time, but all of your trash is on the outside, and you can see they remove the panel in one fellow swoop, not to injure the victim that may be right on the other side of that wall. So we have, when I say we have equipment, it's an understatement. Our cash and what FEMA requires is phenomenal. I mean, even from the medical perspective, I have, over $1 million of medical supplies that we have to have for the FEMA cash. It's about 100,000 pounds, $7 million worth of equipment. It's primarily so in my backpack, my Nimrod back, I'm 72 hours. So everything I need, I carry with me to survive for 72 hours. The cash will keep me self-sufficient for 14 days. So when we go into a hurricane or a tornado or some, other disaster, we really are self-contained for 2 weeks. So I don't have to ask the local judge, I need a building, can you give me power? I bring it all with me. So that's the benefit of the search and rescue world that we live in, is that we really come with everything we need to do our work. And we really don't need to bother you. Just tell us what you want us to do and we're going to go get it done. In addition, Texas, we started the water squads about 10 to 15 years ago because we have a lot of flooding in Texas. So water rescue was not traditionally part of the FEMA system under search and rescue. It has now been added, but we are still the forerunners with water rescue, and you'll see some of that here in a little bit. Here's some of our storeroom caches. When I tell you we got stuff, we got tons of stuff. This is a picture of our warehouse. There's multiple semi-truck layers. You'll see in the back there, those red boxes. That's actually our palletized equipment, and it's on skids. We can be wheels up in 4 hours. So we can load everything on a military airplane, C-130, C-5, whatever's needed. We can get boats, we can get radios, we can get palletized, all stuff on there. You see lots of boats, comm trailers. So when we roll out, it looks like the convoy's coming to town. It's a lot of stuff, a lot of people. So search and rescue, what are our capabilities? We talked about structural collapse. So building collapses, a town, a bomb goes off. I mean, y'all recently just saw Lebanon, the Beirut bombing, or that wasn't a bombing, I'm sorry, the explosion from ammonium nitrate. I mean, that's where really search and rescue goes in and says, how can I find and rescue any survivors? And then after that, it comes to the point of recovery. How can I get, the victims out so that their families can have them back? So structural collapse is really about first search. So our search teams, which will start with dogs or with people walking around and yelling, "Are you okay?" When we find victims, then the rescue teams come in and really start to cut through walls, bust through walls, do all kinds of stuff. And so this is a variety of training pictures. Actually, the center picture is Brittany and Denise Corliss. That's actually one of the stairwells on the World Trade Centers. So we also do wide area search. That's become the more common thing we do. So with the hurricanes that just happened, you can imagine the hurricane went through a large town. And so how can you strategically search a whole section of a town or a small community? And so that's kind of where our expertise has been. We use technology of GPS tracking. We have the available to mark information on a building with hazards, either natural gas or electrical lines or whatever it may be, so that we can mark those for not only other rescuers coming in, but also those other emergency support functions that can either get power turned off, get gas turned off. This is a variety. This top left picture is actually a LoRa wide area search from a few days ago. That center one there is one of our hurricane responses up in Oklahoma. And the picture on the right is from the Wimberley floods a few years ago. So you can imagine, I mean, it's not uncommon for us to walk 20, 25 miles a day. And so when we talk about what's important tool for the individuals, it's their feet. If I told you we were designed for a structural collapse, so our boots are these big leather boots, there's a metal shank in the sole. So if I step on a nail, it's not coming through, steel toes. Can you imagine walking 25 miles a day in those kind of boots? Doesn't work well for your feet. So we were actually one of the first teams to do a wide area search boot, kind of more like a hiking boot. But this is a challenge I have all the time. Looking, they're doing wide area searches here on a hurricane or a tornado, but now they're climbing over debris. So I've had now 2 near misses, if you want to call them, where people have stepped on nails and not punctured the soles, but come pretty close because they're wearing the wrong boot. I did mention water rescues. We're extremely busy, and there's 2 kinds of water rescues. There's flood water, which you see on the top left here. It's pretty easy. I can walk around in it. Then there's swift water, which is really moving rapid flood water. And that's a completely different type of training. We see the Cajun Navy, we see all kind of people coming all the time in swift water without the proper training and end up becoming victims. They flip their boats, they drown because moving swift water is a completely different world. And then you see the top right picture, add night rescues on top of that, and you really talk about some dangerous stuff. Now, from a medical perspective, for me, this is hard because this is nasty water. We learned from Katrina. I mean, we had folks that had weird sores on their skin for months. So these guys have to wear dry suits. They don't come in contact with water. Now, they'll take that dry suit off and they'll pour out a liter of water from the dry suit, but that's water that they put in there, not water that came from the outside. And so you can imagine the challenges from a medical and safety aspect when you start talking about the work duty cycles, dehydration, and other things from these folks. In addition, Texas did not have, or the FEMA response itself does not have helicopter rescue. So we have a great partnership with our Texas military forces, and we actually will put rescue swimmers, helicopter search and rescue guys on military and Department of Public Safety aircraft, which is a great combination because that's not normally what they do. They fly, they do wonderful things, but they don't have search and rescue. So we have swimmer paramedics. And so the left picture there is actually one of our rescue medics actually with the Department of Public Safety helicopter. So DPS, Highway Patrol. The center one there is one of our medics with the military, Texas military, Huey, not a Huey, I'm sorry. Well, it's UH-6, I guess, whatever. I can't even think about it right now. We rescue lots of animals. You can see there chickens, ducks, horses, dogs. People care more about their animals and disasters than they do themselves. Probably some of the weirdest things we've rescued. One house we went to a few years ago, the lady had a 30-year-old tortoise and a goat in her house. So she wasn't leaving unless we took her tortoise and her goat. In Harvey, we got an interesting request to go save some ducks. So yes, we went and rescued ducks. I thought ducks could swim, but what do I know? We saved the ducks. They're alive and well today because of the task force. We also get single source resource requests. So frequently we get requests for our search and rescue dogs. We've had multiple requests for our rescue guys. For instance, the dogs got called into Fort Hood a couple years ago. In Fort Hood, they had a high-profile vehicle go into to rapid water, and there was, I think, a dozen or so military guys that drowned. They found most of them, but couldn't find a couple of them, and so we were able to take. Our dogs are two kinds. So we have live find dogs, which we're trained to find live individuals, and then we have what we call HR, human remains dogs. So they're cadaver dogs. So they were able to take one of our boats and then one of the cadaver dogs, and they were able to go up and down the stream. And so when the dog got a hit, they would go left and right till they got a hit, and then they would go up until the dog lost the scent and come back till the dog gained the scent again. And they were able to triangulate the location where they were able to drop and find the missing soldiers. So it's quite fascinating what the dogs are capable of doing. So my job as the medical director, so fit for duty. So we're in an austere environment. I told you we have to be self-contained. We often don't have electricity. So you can imagine existing medical conditions. I got lots of firefighters that don't like me. I don't get many Christmas cards because I can't sign their medical clearance forms. I can't send an insulin-dependent diabetic downrange. I mean, I don't know when they're going to eat. I don't know if they're going to eat. I don't know if they lose their medications. I mean, nowadays they have wearables. I mean, there's phenomenal technology, but I just told you I'm putting them in water that's contaminated with feces or other biological things. And so you think of people with autoimmune diseases who are on medications to suppress their immune system. Hard for me to put an individual like that in nasty water or downrange in like a multiple post-hurricane. So I would say the number one reason why I don't get Christmas cards is because I can't sign medical clearance letters for some of these guys. We have an aging team in Texas. We're fortunate enough that we have lots of experience, but where you look at some of the LA teams and Miami teams, where their average age is, mid 30s, early 40s. Ours is late 40s, early 50s. We've got guys that have been on, we still have guys on that have been on the original team 20 years ago, and they're phenomenal guys. But every 3 years when they do their medical, I get to call them and tell them, hey, your kidney function's declining. Your blood pressure's out of control. I'm sure glad you're sleeping well with your CPAP, but hard to plug that in downrange when we got nothing to plug it into. So that would be the hardest thing for me, because I really care about these guys. They really are my family. And I know that they respect my decision. They don't like my decision because they're like racehorses, man. They want to go do what they want to do. But it's really hard when I tell them, man, I'm sorry. You've been doing this for 20 years, but the time has come. You can no longer do this. So on the initial screening, obviously the medical questionnaire, we get basic laboratories. We actually do like RBC cholinesterase and heavy metals because of the hazardous materials that we potentially get exposed to. Chest X-ray, EKG, OSHA, the respiratory screening, because we have to, every year, we do a half face and a full face mask fitting, because we have to wear masks a lot in our environments. So new people coming in, they got to tackle the beeson. They don't like it. So I've had technical search guys. I had plans guys who they really want, and they have interviewed them, they selected them, and then they put them through the medical and they can't pass. So I'm sorry, I'm not really a bad guy. I really just want to make sure that everybody comes home and that they don't bring something home that they didn't go out there with. And they come home with everything they went out there with. We also have ongoing recurring. So I still have teammates who were on the World Trade Center. They're still being monitored. So I get their World Trade Center physicals every year. I have firefighters that get annual physicals that send stuff in. And, so it's a lot of really occupational medicine. It's like caring for a bunch of my family members, which is kind of hard when I got to tell them no, or, but it's also a good opportunity for me to work through them. They have injuries, helping them get rehab, physical therapy, whatever they may need. When we go on a deployment with what we call a type 1, which is a full team, it's about 100 people. We have 2 docs and 4 medical specialists. So our docs, we have emergency medicine docs, internal medicine. I actually have a pediatric critical care doc. He does adventures. He's a, adventure seeker, climbs mountains all over the world. He volunteers for some amazing missionary work, and he's a phenomenal doc. He just happens to be a pediatric critical care doc. I got nurses, paramedics that are mostly paramedics, part of our medical specialist techs. When we go out, the whole concept is we're 24-hour operation. So I have 1 doc and 2 medics if we're doing 24-hour operations. That's kind of how the system goes for redundancy. Now, when we select docs and medics, the medicals training is really first the austere environment. We put them in places most people don't want to be. I'll show you some pictures here in a few minutes. We get an orientation to the general search and rescue world. So safety, we get a little orientation to everything. So safety, structural engineer, hazardous materials, rescue, search, all of those things. CBRNE, which is chemical, biological, radiological, nuclear, and explosive. That is kind of what the world's coming to now. So FEMA has now tasked us with CBRNE training. I also get canine training because I have to take care of the dogs. And I love the dogs. This is like kids. I love in the emergency department taking care of kids. I don't particularly like their parents, but I love the kids. And I feel the same way about the dogs. I love the dogs, but the canine handlers are a unique group of individuals. And I'll just leave it at that. The interesting thing is, in all of the FEMA required training, there's no requirement for occupational medicine. And that's what we do the most, which every year we have our medical meetings and I keep raising my hand, guys. I mean, we got to train, we got to change training. You'll see some pictures of really cool stuff we do in training, but we don't do that. We do a lot of occupational medicine, and there's no real discussions on occupational medicine in the medical skills training. So this is our training. It's a week-long training program that all physicians and our med specs go through. It's various locations. These pictures are here from Disaster City in College Station, which is up by the airport, by the fire field. And so we get docs, medics, everything to say, how do you evaluate a person when you can't see him, you can't touch him? So you see there in the middle, he's trying to manage an airway through a little bitty hole. You see the med guys there on the right picture doing just some wide area search looking, because we actually put victims down in these rubble piles. There's tunnels all throughout them, so they actually have to find them. here's some of the patient scenarios we put them in. So you got the guy, so how the heck are you going to get him out of there? And so how do you assess them? How do you decide? I mean, there's the things we know we can do, and then there's things that we should do. So yeah, this guy's dry and dehydrated down this hole. So you're going to starting IVs in a hole. You know, we talked about intubation. Sure, I can intubate somebody in a hole, but what am I going to have? 10 foot of you know, a breathing tube for them. So I'm going to breathe on the outside of the hole while it takes 12 hours to cut them out. So there's as much triage in this, trying to decide not only finding victims, but finding salvageable victims, because there's nothing more than spending 6 and 8 hours trying to get somebody out that doesn't survive when you let somebody else stay in there a day because we didn't do a good triage. So that's one of the hard decisions in medical. But I tell you, we get a lot of good docs, a lot of good medics. You put them in these holes and they're like, you know what, this ain't for me. I don't like claustrophobia. I'm not going to do this. And then you have other folks like me. I could go in a tunnel and sleep for days. So lots of hazards you see, metal sticking out, you know, so we really focus on the safety aspect, having the situational awareness of not totally focusing on the patient, but remembering that there's a whole incident going on around here, keeping aware of situational awareness. Just you know, taking a doctor, teaching them how to do a backboard, how to do things that usually doctors don't do. It's been a lot of fun. I he was actually a hand surgeon out of California one time, you know, trying to teach him how to put on a cervical collar and a backboard, which any EMT can do. This guy's like a qualified hand surgeon and he couldn't figure it out. So just goes to show you being smart isn't everything. It's also making decisions. So this is one of the simulations we put folks in where I have cribbing in the middle of the tunnel. And they have to get around that, because if they knock that cribbing loose, you know, it's a simulation, obviously, but we tell them you're dead now because the whole the tunnel just caved in on you, because the only thing keeping you alive was that cribbing there. But we also, you know, you see the guy there on the left with the mirror. How do you look around corners to evaluate people? We put them in dark and show how you can evaluate and do actually a visual and a hands-on evaluation using glow sticks. And in fact, we actually teach folks, you can actually cut a glow stick open and wipe it on the arm. And actually it's fascinating. You can see veins and things on how to start an IV. So it's pretty cool what you can do with a glow stick. It's probably pretty scary when you come out of the tube and you got yellow glowy face, but it's really trying to get very well-trained medical folks to get outside of their comfort zone. And you can't get an x-ray, you can't get a lab, right? Half the time you can't even put a stethoscope on them. So how do you do a physical exam and evaluate the seriousness of a patient by listening to them breathe, counting how many words that they can say every time they have to take a breath, you know, asking them, can you move your arms and legs? Can you knock 3 times, you know, doing various things to where you can really, I find it makes me a better physician, because I can evaluate somebody probably better through a wall than I can actually seeing them and touching them. So it's been a lot of fun for me. In addition, you can see we spend a lot of time with the dogs and the handlers, those interesting people. Learning, starting IVs. I mean, working dogs are very prone to gut volvulus. So believe it or not, a dog's gut can flip inside itself and it can strangulate its own gut. And so we learn how to decompress that gut volvulus until you can get them to an emergency vet to perform procedures and surgeries. Now, many working dogs, they kind of staple the stomach to the wall so it won't do that. But you can imagine a dog running and jumping all over things, and that gut just will flip on itself. And actually, it's an emergency for the dog. We mostly see, just like humans, lots of foot injuries, which I got some pictures of here in a few minutes. Oh, we're running out of time here. So sick call, you can see. We have the availability of having a hospital. We don't do that. Most of our sick calls are what you see there out on the side of sleeping outside outdoors, because we move a lot. So it's hard to set up tents and take them down and move. What's my job really on deployment? Where do people use the bathrooms? And then walking around all the time with a little card saying, okay, when you pee, what color is it? Are you getting enough water? Do you need more water? Nothing better than, you know, being the pee evaluator. And it's hard to evaluate pee when they're, you know, peeing in a blue can and it's all blue down there. So sometimes you got to think creative. Okay, cut your water bottle, pee in your water bottle, tell me what color it is. So that's the reality. Our greatest risk too is food. These guys love to eat. And so it's really hard to have them eat a meal ready to eat, or an MRE, which is a meal. I mean, it's a 4-course meal and a brown bag. Nothing more exciting than eating an MRE. I Google them, buy some on Amazon. It's the greatest thing to not do. So they love food. People want to bring us food all the time. Every deployment, people bring us cookies. They bring us food they cooked at home, and I won't let the guys eat them, and they get mad at me. And I tell them, you know, that cat call you ran the other day, the lady's got 50 cats in her house, and the cats are crawling over everything. Like, yeah, I know that lady. She cooked that casserole. You really want to eat it? And they're like, oh, doc, man, why would you do that to me? Because I don't want 50 guys eating a casserole that's got cat feces in it, and then all of you got poops tomorrow. We got work to do. So we try to hire caterers, which you see, a lot of times our logistic guys will bring in commercial cooks with kitchens. And really, they're phenomenal. They drive hours to get us Whataburger. Whataburger should actually sponsor the Texas Task Force, because our guys, this is in Hurricane Michael. They drove an hour and a half to get me my taquito for breakfast. God bless the logistics guys, because they know I need my Diet Coke and my taquito. Short of that, life is good. So really our greatest risk is food service. And then you can imagine sleeping quarters in respiratory protection. Now, this was taken a few days ago. The president and Cruz and all the guys came down there. They were really good about wearing their masks, but I guarantee you, when that camera turned off and Senator Cruz was gone, they all took their masks off. And so it's, you know, I continuously have to pound them, wear your masks, wear respiratory protection. We don't often know what we've been exposed to till weeks later. Medical reality, this is the greatest risk, their feet. I got to take care of their feet. So they all know at dinner time, get your food, come show doc your feet. I don't care if you haven't taken a bath for 3 days. I need to see your feet. The dogs, the same thing. You see a dog here lost a nail. So what's the most important tool for a search and rescue guy? It's their feet. Take care of their feet, take care of their feet, take care of their feet. And then the work duty cycles. I talked about the dry suits. Now you can see the biological chemical suits there. It's really tough when they're spending hours in those suits and it's 100 degrees outside. So work duty rest cycles, trying to get, you know, here's Brittany again with Denise, trying to get the dogs, trying to get them to lay down, take a nap. It's pretty tough. Now, we've got the dogs chipped where I can do a scanner over the dog's back and know what the core temperature is on the dogs. I threaten the other guys, I'm going to chip all of them if they don't start taking a break, drinking water, and getting out of the sun. And sometimes that works, sometimes it doesn't. So this just talks about the call. We're on call. When we get called out, it's an automated call. We got 3 hours to drop what we're doing and get to College Station, because we have to be out the door in 4 hours. The medical clearance is looking for injuries. Now, I've screened them, but we still look for illness and injuries, because I don't want some guy with COVID, some guy with the flu coming on a deployment, getting 100 other people sick. We make sure they have their routine medications for 14 days, because if you don't have your medications, don't come. I'm not your doctor. I'm not, going to tell you to take your medicines. You need to grow up, be a big boy, put your big boy panties on, and take your medications like you're supposed to. We also work to clear the dogs. Got to get all the medical cash together. The medical cash, the cash is supplies. Also, somebody asked about that. All those medical supplies, we got to get ready, get them loaded up. Then I start finding where we're going. What's the medical infrastructure? Is it a hurricane? Is it a tornado? What's the local hospitals? What's the EMS like? I start finding veterinarians. If we're driving across country every 60 miles or so, I find hospitals so that if we have an event, I know where we're going to send our team members to. So that's one of the responsibilities of the medical team. Then when we get set up, we got the base of operations, just like a medical clinic. You sick, come see me. I want to see your feet every day. Our med specs go out with the teams. And so they're our forward eyes. They're the paramedic up front. They're the safety officer. And then one of the team members usually stays back with the task force leaders. That's what TFLs, and the base of operations, which is the BOO. Lots of deployment challenges. Most of these guys are medics at home, not my medics, but the rescue guys are all medics, and they think they know how to take care of themselves. So it's tough sometimes. Rest duty cycles we talked about. Making them wear their PPE, making them wear their masks. And then victim handoff is one of the things I really focus on. So if I find somebody, I don't want to spend an hour waiting for an ambulance. So I now actually start taking FEMA ambulances with us when we go work. So when I find somebody, I can hand them right off to the medics on ESF-8 with an ambulance and transport them to care. And then, of course, the shoes. What boots you going to wear? Wide area search, structural boots. And the demobilization, it's a lot of syndromic surveillance. So what have I been exposed to? Water, some of the fires, asbestos. Doing a medical exam, making sure they don't have injuries that they didn't know about, and then if so, following it up. And this is true. Disaster medicine is mostly occupational health with a little side of public health. So where's the bathrooms? Where's food? Where's water? All those things exciting. We'll quickly run through some. This was the bonfire in Aggie at A&M years ago. We got called in to help rescue folks. Unfortunately, we were in A&M. I mentioned many times the World Trade Centers. Our saving grace, one of the docs that went to the World Trade Centers was an anesthesiologist, and he pissed our entire team off, making them wear respiratory protection where others were not. And it was tough. About every hour, they had to change cartridges because there was so much contamination in the cartridges. But I'll tell you, we've had 0 of the Texas task force that have had the World Trade Center lung. And it's all because Minson made them wear their masks. And they hated him at the time, but, well, they still hate him. But anyway, he saved their lives. This was the West explosion. This was one of the first explosions we had. I found it fascinating, the physical forces. I mean, some of the pictures I took of trees pushed back. I mean, you can see the bark stripped off of this tree and that limb shoved in there. I have no earthly idea how that happened. We've been to Oslo, Washington. They called in the mudslides. They asked for human remains dogs. And so we sent dogs to Washington. This was back in 2014. The Wimberley, this was, we were 2 weeks of flooding in Texas. And you want to talk about, we were tired. We've been there 2 weeks. And the last night, the flooding happened. And it was just completely devastating. I mean, there were so many calls for service. It was the middle of the night. Our water teams couldn't get in the water. One of our teams launched in the water, and the minute they launched, a house went floating down and was destroyed by a bridge. So they rapidly got back out of the water. So it was horrible. In fact, there's still 2 children that have not been found from the Wimberley floods. Joplin, Missouri was a large tornado, big wide area search in 2011, had lots of dog injuries. You can see one of the dogs there with his foot wrapped up, which is a bad thing for the dogs because you say, why can't you put shoes on the dogs? If they can't feel their feet, they trip and fall over everything. So they really have to have their feet down on things. Bastrop fires there around central Texas was a wide area search. This was hard because it was hotter than hell and they have to wear fire suits, which is even hotter. So lots of dehydration, lots of work duty cycle. More Oklahoma. It seems like every couple of years we go to Oklahoma. This is Tornado Alley. It's crazy because you're doing a wide area search, but as you can see that one picture on the left, a lot of these people have storm shelters. So they're like in their garages. So their houses collapse down on them and they're down inside the storm shelter. So trying to find those people. This is some helicopter search and rescue with the weather back in Wimberley in 2015. This is more water rescue flood waters in 2015. They learned how to load a boat on the back of a military vehicle, just practically sink the military vehicle, which it'll run in deep water. So just don't show the general that. It's too deep. Hurricane Michael, typical hurricane, lots of devastation, went rapidly up into the panhandle of Florida. It was really devastating. Hurricane Maria, we actually got deployed to Puerto Rico, which is loading everything up in a plane, which even becomes more of a difficulty because then you really can't get resources. I mean, when you're on an island, it kind of limits what you have, you brought, and other stuff may be coming, but it's a long time away. And so the challenge of getting around and searching the island was very difficult, as you can see with a lot of the pictures there. Puerto Rico's been hit many, many times hard, but Maria was one that we responded to. We got called out to the San Marcos fires to help the Texas fire marshals. They suspected arson with this, and so they needed us to shore up a specific area over this area here where they thought the fire had started. So we had to go in and shore all this up so they could go in and investigate. In addition, there was human remains over here that you could smell, but we had to use the dogs to find it over here. So one of those deployments. This is Hurricane Laura, which we just went on. Lots of dog rescues. This actually they all run together. This is the H hurricane that we just had. I don't even know the name of it, but this is Corpus Christi. One of our rescue squads got called out to save a couple that decided they were going to ride the storm out on their boat. And about halfway through the storm, they said, help us. And the Coast Guard said, nah, we ain't going. And so the Texas Task Force went. So what is this disaster medicine for me? Lots of family sacrifices. This is me on Hurricane Michael. FaceTiming my wife. It was our anniversary. She was here having a great meal and a glass of wine. I was sleeping in a storm, eating a pepperoni pizza out of a MRE bag. So it was, the family sacrifices are phenomenal. They never know when we're going to go. They never know when we're coming back. So I can only do this because my wife puts up with it. It is a never-ending story. This is one of the park rangers. It was Gustav, then it was Hannah, then it was Ike. I mean, that year it was like storm after storm after storm. We never got a break. But there's the personal impact. I mean, West, there were public safety, there were firefighters, there were our family members that got killed fighting this fire. In fact, a lot of the Dallas firemen, one of their fellow Dallas firemen was a victim in this fire. And so the human impact, the personal impact when one of our own gets injured. We had a water squad from California get sucked into a culvert a couple of years ago during Harvey. Fortunately, they went out the other end of it. But I mean, there are risks to search and rescue. But I find the emotional impact. I mean, this is a shoe I came across in West, and I had young kids at home at the time, and you're thinking somebody's life is just devastated. You see the kids' toys, you see people in seeing the stuff. People evacuate with everything they own in a Walmart bag. I mean, that's it. It's extremely an emotional thing to deal with. But we got great federal partners we exercise a lot with. The civil support teams come out, helped us out in West. They helped us out at San Marcos, where they're able to analyze the air and give me information on what kind of chemicals we should be worried about in our safety teams. This is one of the federal decontamination teams that go around solely for mass chemical or biological decontamination. We're still working on a patient tracking. It's always something out of a disaster. We haven't figured it out. This is one thing we tried a couple of years ago, taking pictures so you could see the victim, and also the bar scanner, you could zoom in and track that individual. We're still working on those things. Technology is going to change as we get more unmanned vehicles, search and rescue devices. I think is quite fascinating. But for me, it's a camaraderie. Brittany there, the dog, she was the last surviving dog from the World Trade Center. We had to put her down a couple years ago. And then obviously Denise and her, they still have dogs. They're still part of the team. But, Brittany was a phenomenal dog. The veterinary world got a lot of great studies and research out of her. And what she was exposed to, because obviously they were in World Trade Center, and the dogs don't have respiratory protection. So they're breathing everything in. But to me, it's a family. When I was in medical school, I wanted to join the military, and my wife simply said, "You can do it, but I won't be here." So this was my way to participate in something bigger than myself. This is my team. We have 3 teams. So Texas 1, there's a red, white, and a blue team. I'm on the white team. So. But this is the size of the team. It's a good group. So what's my summary to y'all in the last 10 minutes is, train often, be prepared for whatever you choose. Search and rescue, medicine, whatever. Be prepared. Train for what you're going to do. Communication. Every after action review from any type of disaster. Communication is always something that can be improved on. And always be open. Always be open to new ways of doing it. Here's my advice to y'all. You want to go to medical school. Do more than make good grades, because every applicant has good grades. What else makes you different than the 1,000 of other good grade students? So find your passion, volunteer, shadowing, all those things, which I know are hard right now. And I know Ray's talked a lot about that. But I want to learn the how and why to everything. Because you know what? When the IV pump doesn't work, or something breaks, a stretcher doesn't raise in the emergency department, give me a pair of pliers. I can get underneath there and find out what's wrong to get it working. So it's be very open. Whatever you choose to do, don't just be the doctor, right? Be part of the team. Treat the least as the most. Treat the guy who cleans the bathroom better than you treat your colleagues. Because, Paris came to a halt years ago on strikes, and it wasn't the doctors that went on strike. It was the trashmen that went on strike. So remember where you really fit in the hierarchy of the world's needs. Don't take yourself too seriously. Laugh at yourself, have fun, and work hard and never give up, man. If you want to be a doctor and you don't get in the first time, keep doing it. Keep doing it, keep doing it, keep doing it. I'll say one final word is, remember that people don't care what you know until they know that you care. People don't care where I went to medical school. They don't care that I'm a DO. They don't care that I graduated last in and I didn't graduate last in my medical school class, but it's funny anyway. They don't care that I trained at Parkland. Really, they don't care. What they really care is that they know that I care. And here's the story I'll tell you. On Michael a few years ago, we were back searching a very remote little town, and there was a lady that had multiple sclerosis. She was bedridden. She was back up there, and she didn't want to evacuate. The local people were running fans to her house. And I've been driving around all day long, and we had an ATF agent with us for force protection. He'd been with us for days. And they get us called back to talk to this lady. They wanted me to talk to her convince her that she needed to get out of here because power wasn't coming on for a long time and she was sick. And so I went back and I went up and introduced myself, told her I was one of the physicians, told her my concerns, and, you know, really wanted to help her and talked her into letting us get in an ambulance. When we left the house, the ATF guy laughed. He says, "Man, you told her you were a doctor." And I said, "I am a doctor." He says, "You're a doctor?" I said, "Yeah, I'm the medical director." And he says, "You've been driving the task force leaders around for the last day. I thought you were their chauffeur." "Yeah, I'm that too." So to me, one of the great things is you don't have to tell everybody what you are. Show them what you are. Do a good job. It's in show them that you care. All right. What do you want to know?
Jeff, what a wonderful talk. That was just marvelous. I mean, it was interesting watching the folks, and everybody put thank you in chat. Let's have 1,000 thank yous for Jeff right now. Keep your eye on the chat for a second, Jeff, and watch all these thank yous pop up. The folks on there says, "I wasn't born before 9/11. I had just started Parkland a couple of months before for when 9/11 occurred."
Yeah.
So Jeff, how does working in disaster medicine affect your mind, your mental health? How do you keep from going crazy or sad or, I don't know, despair from all the disaster and the damage that you see?
So really, it's the opposite for me. It brings me down to earth because I think we lose sight of what's important, right? We got our houses and we want to make good grades and we worried about our cars. And when you go to people that lose everything and really they're just glad to be alive, and you know, and some of these folks have been through multiple storms and they just keep coming back because they love their community, they love their family, and you know, to me, it really, you know, it brings me back down, if I'll say. It really reminds me what's important and what's not so important. So it's my therapy in a sense. Yeah, it's hard, depressing when you see people lose their lives, lose their homes. But for me personally, it's rewarding. I get to help people. I was never in the military. I should have been, but I wasn't. This is my way of giving back, and truly in an organized fashion when disasters happen, because most disasters are very disorganized. And so being part of a team that's very organized, it gets to come in and I mean, we're in and out and so fast, people don't even know we're there half the time. And it's fun to be part of a fine-tuned machine.
Several people have asked, are there opportunities for students or folks getting in med school for Texas Task Force 1 and 2 for SARTEC?
So we don't, no, not for task force. We do have a lot of members that are on other more volunteer search and rescues, regionalized stuff. There's equine search. There's some local search and rescue teams that people volunteer for. Team Rubicon is another one that people volunteer for a lot. It's a very well national respected coordinated response. And they're out right now in Lower. In fact, one of our PAs from the university, after spending time with me, he went off with Team Rubicon. He was out is the medical helping them clear roads with chainsaws. So there's lots of opportunities for disaster response. There's opportunities for shelters. I mean, you could volunteer, right? When we had the shelters in Dallas, and you know, there's always opportunities to help in these kind of disasters. Teams like ours that are very organized, that have specific roles. I've had some fellows that have come and kind of trained with us and stuff, but they're non-deployable. They later want to join teams. They do that. Texas A&M used to, I don't know, they still do. They used to put their medical students through the medical training course. So there's always opportunities, and happy wherever you're at, you know, shoot me a note and I'll put you in contact with some guys local to wherever you are. I saw logging on, there were some guys in Puerto Rico and California. There's guys all over the place. So.
And
I
so
just posted the link to the Medical Reserve Corps as well. It's another good opportunity for people who may not have the certifications. They're all over the place.
Very true.
Right.
Medical societies have reserve corps. Yep.
So to be a doc involved in a task force, do you have to be an emergency doc, or do you have other types of positions that?
All kinds. You gotta have a license. Actually, to me, it's more about having the personality. When the team went to Puerto Rico, the FEMA guys showed up and they needed a doc. Something was wrong. And, you know, they asked, "Hey, where's your doc?" And the task force leader pointed down to a long-haired guy, looked like Shaggy, and he was helping unload boxes. And he's like, "There's our doc." And the guy's like, "That's your doctor?" So, you know, to me, that's what I want. I want a person that's going to not, you know, I have a few that let everybody know they're the doctor. And by God, they're not unloading the box and they're doing nothing because they're the doctors. But they were there when I got on. Those are not the people that I've selected. I want the people that are just as happy unloading boxes as they are taking care of people, because that's how you become part of the team.
To let everybody know, we'll go about 2 more minutes and then we'll knock off. What if you're in Task Force 1, but you live further away than 3 hours from College Station? I mean, what happens? Do you put in another group, or you just can't participate?
Well, if you can also go to Texas too, if you live within the time frame of the Dallas-Fort Worth area. We have some docks up here that are too far. It's a thing we're discussing, especially in Texas. The Department of Emergency Management has a need. We've started some rapid response teams down in the Valley. I don't have any medical folks down there right now. So I think as we get more state involvement, the FEMA scene is very structured, very hard to change, but the state response is much more nimble, at least in Texas, and I'm sure in other states. I could get you in contact with people in other states. I know there's folks from all over. I just am very familiar with Texas.
2 or 3 more questions. So what do disaster medicine specialists or team members do when there isn't a disaster? Do they have other practices, or just what do they do? Or
everybody's got another job. So we've got some, in fact, that's part of the problem with doctors. So a lot of ER docs, it's hard, man. When you get a call to deploy and you got 2 shifts tomorrow, it's hard unless you're with a big group. Nobody wants to cover your shifts. They don't want extra money. They don't want extra time. They're tired of working as it is. So it's hard to get it covered. In fact, the pediatric critical care doc I told you about, he rarely can go because his partners don't want to cover him. The EMS physicians like myself that are academic docs that are part of big practices are easy to go. We have a couple of family practice docs that just shut their practice down and go, and it's something they love to do. So it's really the Shaggy guy's telling you about. He's actually at A&M. He's a family medicine sports med doc. He's the Aggie football doctor, right? So he's no use to me during football season, but when football season's over, he's ready to go. He'll jump at a heartbeat and go. So,
last question: do you ever quarantine after your own trips?
That's funny. It just came out. So no, we don't. I mean, we monitor. I have lots of folks that are, often injuries monitoring, but like this COVID stuff recently, we have the ability to test symptomatic people. In fact, the other day we were testing everybody that was near the President of the United States. The Secret Service came in and gave us machines that said start swabbing everybody's noses. So Dr. Benitez, he actually did it. He texted me, he said, "What am I supposed to do with this?" I said, "Listen to the Secret Service. I don't know what else to tell you." We have not. We screen people, we monitor people, we test them if needed. But everybody should be wearing appropriate PPE. So although they may have been around people, they should not have technically been exposed if they're doing what they're supposed to do.
Our students said 2 things among many other. They said, "Your story is so interesting and inspiring, Dr. Beeson. And the stories you're telling are so freaking cool." And then Vanessa said, I hope she's still on, she said, "Your honesty is gold." Jeff Beeson, my friend, my buddy, one of the great docs I've ever known and one of the most courageous individuals I've known. And thank you for your service in Hurricane Laura. Thank you for coming to these 1,300 students that joined us tonight to hear you live. And on behalf of the whole virtual shadowing working group and all the folks who came to see you tonight, Jeff, thank you so much. And thank you for being with us.
Thank you, guys.
So everybody, the exam will be posted very shortly. And just remind everybody that we'll be back next week to talk about some other things. So have a great night, and we wish you well from the virtual shadowing group. The last slide, the quiz will open 15 minutes after the live session ends. The password will not work at the moment. We will post on our Instagram and group me when the quiz is posted. So there you are. All right, everyone. And take a quick look at it'll be on the website in about 15 minutes. I've got to put it up there. So with that, y'all take a quick look at the pin and the disaster. Password is disaster. Jeff, thank you again. And from Virtual Shadowing, we wish you all a good evening. Thank you and good night.